We are getting into some sticky ground this morning. We joined by two guests, and one of them is already here. Dr. Davji Atellah is the Secretary General of the KMPDU, and he's here with us this morning. Good morning, Dr.
Good morning, Drew.
How are you doing?
I'm fine. How are you?
Fine. I'm fine.
Yes.
I'm fine. And Dennis Aseto is here, and Dennis Akari is here, and we have some things to see if we can open up a little bit, because there just seems to be a lot at the moment, from unpaid insurance to not being able to take care of health needs to many things which we'll be talking about later as well in terms of medical workers. But we're here to open this up, and necessary for us to have that conversation. We'd like to hear your interpretation of the proverb that Seto will share, if you would.
Yeah, so the proverb today comes from Zambia, and when we talk about Zambia, we're looking at a country whose economy is being pushed by several factors, so agriculture being one of them, but then again mining takes the lead because they are the biggest producers of copper, cobalt, and tourism as well, and energy in the country is doing very, very well. So when we talk about agriculture, maize, like Kenya, is the staple food for them, but for them they produce something called shima, and shima is porridge, and that is their national delicacy. So that is their ugali, their form of ugali there. But let's go to the proverb. A small tick can cause great sickness. A small tick can cause great sickness. How would you interpret that?
That's you should never ignore a small issue, because then it is from that particular small problem that a big one can emerge. Just like a small leak in a ship can make the ship to capsize. So yeah, it's just telling us that we should not ignore something that it's small. It's out of that small that the serious problem, catastrophe occurs.
Yeah.
Indeed. Well put. Dr. There is quite a lot that's going on when we look at, the health system, the sector at the moment. Of course, there's a lot of complaints, there's lamentations, and some of those are grounded in fact and not emotion. We do know, obviously, that there has been the sentiment from a lot of folks that, SHA is not working, and they say that based on what somebody else has said. But then there are very many an individual who have tried to go through the system and it hasn't worked for them. Giving you some examples, there are people who have paid up 1 year and they have then gone to hospital and they've been asked, well, unfortunately, we cannot offer, you must pay cash. Most recently on Monday, we have seen that civil servants who make up a particular tier will not be able to access. They're asked to pay cash, even though this money has been deducted at source, and in line also with private insurers where they're not able to access this care. It just seems that thing after thing is going on. We saw regional SHA offices close the other day, and now we are seeing that those who go outside the country for treatment with an accreditation by SHA are not going to be able to access healthcare for the time being. There seems to be so much going on, and we've just got to ask, it would appear as though there is no handle on healthcare at the moment. Is that the case, or are these bumps in the road?
They may appear like bumps in the road rather than saying that there is no healthcare in entirety. But I believe that the change that is being done by social health authority is to ensure that there is coverage of healthcare, but the way it's being done, the speed at which it's being done is what is causing the problems that we are seeing. I believe that this idea that those who are abroad or seeking medical care abroad, their packages being stopped, is not something that is actually good, in the sense that there has to be a plan, because those people already there having been approved to seek care, even if the government is to relook at the packages of the medical insurance for those particular services that are there in the country, this one should be covered. To the point that you tell somebody that is going to go next that if that particular service is available locally, therefore you should not actually stick it out. But anybody who was approved and is already in, for example, India or Egypt or in another country, when you say that we are not going to pay and they're totally dependent on that particular insurance, that becomes quite unethical, and that thing cannot go well with anybody, and including the government that is doing that, because those particular families will be stranded or they'll be forced to sell all their properties, and that is not the basis of insurance. When you're covered by the insurance, the agreement that is set forth should cover you when you need that particular care, and once it's been approved, there's no change change midway. The other thing that the access to care with insurance companies, for example, in public facilities, one thing that has come out glaringly is the outpatients medical services, particularly level 5 and 6, where they tell you must get sick care in level 2, 3, and level 4. But then we realize, as much as government has been saying the primary health care is free, there's some hospitals, for example, in Kiambu, which were charging patients when they go to those particular facilities. So it was like, how do you say these level 2 and 3 are free when we go to those hospitals and we get charged for this particular services? That was a concern that need to be resolved.
So why are people being charged in that example of Kiambu when the government has pronounced itself over the issue?
I was with the advisor of the president yesterday, Dr. Thuranira, and he was telling us that he had asked the governor of Kiambu that, why are you charging? The governor actually said they were not charging patients. So he had to pretend like he's a patient in Kiambu. It's one of, I think, level 3 hospital and level 4. And he had to pay to seek the care. So there's the aspect of the policy and this aspect of implementation. So if there's no alignment between the national government, which actually handles SHA, and these county level hospitals 2, 3, and 4, then that becomes a problem. So that's one thing that comes in. Then there's a bigger problem of the civil servants, whereby we saw the Kenya Health Federation say that they will not be giving services to the civil servant. On one point, they are very right to actually say they won't give the care. But on the other side, we were feeling like the private hospitals are using the much needed services by the public servant to use as a bargain. But they're right on one hand that when services are being given by any hospitals, they ought to be paid. Then we realize that from 1st of October 2024 to the time that they give this notice, they have not been paid. It's only when they issued that notice that civil servant will not get care that I think money was paid to them. So sometimes it's out of the actions of the private hospitals that forces social health authority to actually pay the money. Yet we have a lot of debt still in many hospitals. And the reality is the healthcare can never be free. It's either the insurance pays or the Kenyans who are sick to pay out of pocket.
So, Dr. Just let's back up a bit and look at that example of Kiambu and the conversation that you're having with Thuranira. So a patient walks into a hospital. Yes. You've been told by your government that this and that hospital, you can go and get treated.
Yes.
So you walk in. SHA is a medical cover.
Yes.
So you walk in, you're treated.
Yes.
Then you go to pay. And then you're told you have to pay cash. So there are two things here. There is the patient who is expecting a service. Then they're expecting that SHA is going to work. Then there is the hospital that now says that you cannot pay SHA, you need to pay cash. What really is the issue? Is the issue that they can't access the system, or they can't extract the information of the patient, or it's a claims issue? So if we allow you to go away after SHA is cleared, we will have a difficult time getting this money back. What really is the issue for somebody to fully understand what we're dealing with?
I think it's a lack of awareness, maybe from the patient point of view, and also just sometimes some county governments or some hospitals going rogue. And in the sense that when you have signed it as a level 2, level 3, or level 4, that you say to be of a primary health care, that you get your funding from the capitation. So it then means that from the point of consultation to the point of triage, to seeing the doctor, and to getting the drugs, you should not be charged. But you realize that you will be charged from the point of getting into the hospital administration, whereby you're going to consultation. And that's the spot check that he did. I had after he did that, there was a memo that came out from the county to all the facilities that they should not charge this particular level of hospitals. But that is just one point out in the entire country. So it means there is a problem. The patient must know that because I have social health authority, I should not be paying in this primary health center.
But the hospital tells you have to pay cash. You're just one person. How do you tell a whole hospital that SHA has told me that the government has told me I should not pay cash? Who do you tell this?
And the same thing, these particular hospitals need to, I think is a reality. There's a problem here, and the problem is both from the social authority that says this level 2, 3, and 4 are free.
Yes.
But then you are going there when these particular hospitals or administration are charging you. So there has to be a way that these people are put to account not to charge the patients, and that's what is lacking.
The other thing we've seen, as I finish my train of thought, the other thing that we've seen. In some instances, SHA works for certain people. Like if the four of us, we said earlier on, if the four of us walk into a hospital, we've all registered SHA. It's not too clear because you hear stories. I even have personal stories of people that I know who've gone to hospital and actually SHA has cleared their bills. I know. But then for others, and they've registered, they've paid the premiums, but they still don't get cleared. How does the system change? It's almost like gambling, like a slot machine. How does it work that a setter will walk into a hospital, SHA will clear his bill, and who walks into a hospital, her bills will not be cleared? How does this happen?
And we're both fully paid up.
Yes.
I think this comes to question that we as a union have brought up a lot of time regarding the benefit packages. You realize that you go to the hospital, and by the way the structure of SHA has been put is that it doesn't control how much an hospital is charging a patient. So if you go to hospital A and then you, for example, getting a cesarean section and they're charging you 100,000, and the other lady goes to another hospital that charges, let's say, 30,000. So the package that have been put in this particular SHA is 30,000. So it means that the person who is charged 30,000 will cover in full. But where you are covered, charged 100,000, they'll pay 30, and you have to pay the difference. That's what they call copayment. So that copayment can actually, at most occasions, make patients to pay extra and above the costs. And that's why I think in 2022, during the NHIF, we were saying that when an insurance company like SHA, which is like NHIF at that time, had an agreement with hospitals, it should be a compromise such that if a patient goes there, there's nothing like copayment, whereby the hospital say that they have used extra amount of extra equipment or consumables that you have to pay extra. Because that's the reality. If you go, for example, today and you get a service in let's say Nakuru level 5 hospital, and you go to, let's say, the former Medial hospital, the same services, there'll be different costs. And therefore, the capping that is there will make a patient who's going to Medihill pay extra.
Yeah. So, Dr. we look at SHA and the payment that is there, because now you find that hospitals are demanding that they be paid for them to be able to render services. And we look at a situation where hospitals have said, we will not offer services to civil servants if we are not paid. And it's upon this point where then money is disbursed to the hospitals. And this brings the question, why is it a question of we have to arm twist and bring people almost to a chokehold for these monies to be released? If there is a service that was offered, the next thing is to just pay. Why must the government be forced to pay? Why is it just not automatic?
I may not speak for government because I don't know how they think about it, but the reality is there are always periods that should be ascertained that after you offer services, the payment should be done.
Right.
Some should be 30 days, some agreements take 60 days, some agreement takes 90 days. And therefore, it's in all honesty wrong if the 90 days period is exceeded without these particular payments being done, because then it means the hospitals are put in kaput. They can't actually run, they can't offer the services. And that's why sometimes when you see the uproar from the rural hospital associations or from private hospitals, even public hospitals, because they are owed money and therefore they can't run. You can't be expected to have doctors, to have nurses, to have the drugs if these payments are not done. And there has been several pronouncements from government that we are going to pay all those who are below 10 million. They say that we're going to pay all those who are owed after they say, verification of the data from NHIF. But in all essence, if these processes are not done within a given timeline, then it causes the crisis we always have in healthcare, where the providers are feeling compelled to take actions before they actually provide this healthcare. Yes.
So Kenyans should understand that even when hospitals say we're not offering services, it's not that hospitals don't want to offer services because they've not been paid.
It's because they can't afford to, because as I told you, healthcare can never be free. You have doctors, you have nurses, you have all these healthcare workers, you must pay them.
Yes.
You have the consumables in the hospitals that must be refilled to actually make it possible even to do lab tests. You have, when you go to the hospital, you must get drugs, and the drugs to be supplied in the hospitals, they must be paid for. So in case you offer these services and payment are not to be done, for example, by Social Aid Authority or any other insurance, there is no possibility of that hospital being able to provide care. And that's why some hospitals were using some unorthodox means, like they will detain a patient. You go to a hospital, they treat you, and then you have a bill of up to, let's say, 10 million. At point of discharge, they feel like there's no mechanisms that they have to get this money. Yeah.
And let's face it, the hospitals are businesses.
True. Yes.
So, I mean, usually when we look at something like this, we look at a problem, and it's easy for us to say, well, it's not working, so damn it to hell. But maybe to understand why it's not working, we need to look at how it should work. So maybe you can help us out with this, Dr. Although, yes, you don't speak for government, but you were in those circles when all of this was being developed in terms of how it was going to work, yes? So, as with any system, if 1 to 1 million people pay premiums, they pay a certain amount. In this case, it's a 2.7. Whatever percentage of what you earn. 2.75%. Thank you very much. Of what you earn, that goes into this pool. And we also know that not everybody is sick at the same time. That's why it works, because everybody puts some money in. And at different levels, the government also puts some money in. Now, when we talk about money being put in, it's not necessarily that there's a pool sitting somewhere. It means that facilities will offer the medical service and they will bill the government, right?
Yes.
Now, if out of 5 of us, we've all paid, likelihood is that maybe 2 out of 5 of us at any given time will then present themselves to hospital. Now, at the tier that is being refused, that you must now pay cash, that's the tier where you've already made your payment. So that's how it should work. So if the money has already been received because it's been deducted at source, or you've paid if you are in private business or whatever the case may be, so where would this money go that then does not allow treatment to happen when you present yourself to hospital?
I think there are multifaceted of issues that sometimes make a challenge. The reality is, when there was an overhaul for NHIF to Social Aid Authority, the drive of government is for the universal health care. That is, every Kenyan should be able to access the hospital devoid of the socio-economic status. That if you go to the hospital, whether you are a farmer or any case, you should not be worried about funds. But that means that this particular Social Aid Authority must have money, and there are only 2 ways to get money into it. One is the deductions from the workers, the salaried, and from those in the informal sector. And we all know that the salaried Kenyans make only 20%. The informal sector make 80%. And as much as we all say roll out, people should register for SHA, it's just to ensure that there's a bigger pool for this money to be utilized. The other part of it is that there has to be tax that inject money into this, and I think that's what they're doing in the primary health care. But how much did they put last time? It was actually very low. So you see, when we have less money, it becomes very difficult to actually make it possible to access the health care.
So is it possible that government doesn't have money to put into that tier?
I can't directly say government doesn't have money, because when you look at the collections they're having now, vis-a-vis the collections that was there in NHIF, we realize that they're not collecting more. At this particular point. In NHIF, with the collections they were having, the loss ratio of the coverage was at 81%. It means there was always balance of funds after a particular year. So it means, what then it means is just the system. The government must get a way to deal with, to have an engagement with providers, an engagement with hospitals, an engagement with workers, so that everybody knows what is happening. Because sometimes you realize they will say the calendar year affects them disbursing the funds. So it's more of a disjointed communication between the Social Aid Authority and the hospitals and the workers.
But should we be at pains, really, to then keep saying that it is working? Should we be at pains? We shouldn't have to say something is working. We should actually see that it is working. Because if universal health coverage, in what it was deemed to be, whether we look at the Uhuru Kenyatta administration, where on the Big Four agenda, access to healthcare, universal healthcare, was one of the items, and that we see that translating into the Ruto administration as one of the, again, it's a big one. But should we be at pains to explain that it is working? Should we be at pains to say tier 1, tier 2, tier 3, or collections? If it's working, should it not be working?
I will not entirely say that social authority is not working.
Mm-hmm.
I think that would make me a liar, because the reality is the inpatient coverage of this particular social health authority, to the best of my knowledge, it covers almost 95% of those who go seeking care there for the inpatient. So depending on which facility and the packages that are put there for the patients. The biggest challenge that has been there is in the outpatient and also in the chronic conditions. For example, you see, before with the NHIF, if you had let's say cancer and your family, once you exhaust your package, which was then 600,000, then you will easily use your spouse's package for 1 year
to cover.
But with social health authority, it is that money. If it's exhausted, you have to wait for the next financial year. I am a victim of this particular problem because, for example, my father was using the chemotherapy for 6 months. For 6 months, you get the 550 will cover him for that 6 months. Then he has to wait now. So those periods you have to pay cash for that particular next 6 months before it was
kick in again.
Before it was easily being covered by NHIF. When we raise this particular problem with the ministry and with social authority, they say they're going to raise that amount to, I think it was 700. Initially it was 300. It was raised to 550, which is not enough. So they say they're going to do it to 700. So those are some of the problems that are actually existing. But saying that doesn't work, that would be a lie. Because for this first 6 months, it was covered. It's just that the new 6 months was a challenge, which then now has to be sorted out. Why? How? They have to locate money that is good enough for these particular patients. And this is not an isolated problem. It's a problem that actually affects many other patients. Because, for example, in the ward where my father is, there are other people there.
Sure.
Yeah. Who then cannot be paid for. So they have to really wait. And so when you are waiting, in such a scenario, it means your disease is progressing.
So can we say that something is working if it's working halfway? Because if you want to say, when you describe or characterize something as a thing, you do so in completeness, in wholeness. Now, can we say that because it has worked at a certain time, then in the next 6 months, if it doesn't, do you then say that, well, it worked and it's not working now? Can you say that the system works? Can you say that in all honesty?
You see, in all honesty, you have to bring up the issue of what are the challenges that are existing in these systems and what are the cures to it and what mechanisms can you bring to change these. For example, this thing of chronic
and critical care.
Yeah. Initially, they were given cancer diseases 300,000. It's out of concerns and complaints that went to 550. That it means that now when you're pushing it to go more, it should go more. It's the same thing with ICUs. Initially, it was at 4,000. Now it has gone to 27,000 per night, 28,000 per night. So in reality, we're looking at there has to be that aspect of bringing real challenges. The people need to go to the hospital and feel like this is the problem. But the biggest concern that I keep on saying, the aspect of co-payment. There has to be conversations to ensure that whatever has been put in benefits and packages is what covers everybody without any hospital or any doctors or nurses or hospital asking you to add more funds to it.
Here's my problem.
Yeah.
We have a good plan.
Yes.
And we've actually consistently said it's not that SHA is not completely working.
Yeah.
It's the confusion of when it works and when it doesn't and why it doesn't. I'm looking back at NHIF, and the question here is around the transition period and whether we were legally, policy-wise, and infrastructure-wise, looking at the system, the softwares and everything, ready for this thing. Now, the initial rollout for NHIF started as a department at the Ministry of Health, not as an independent fund. Then the rollout was very gradual and controlled. And then initially, the contributions were compulsory for formal employees through payroll deductions. That's how it started. Now, the benefits at that time were limited to inpatient care in government hospitals. There was nothing like private, only government hospitals. Then the registration was automatic for formal employees, while voluntary for the informal sector. There was nothing forced. Now, when you look at the expansion after moving from our department, the initial phase was limited to public hospitals. Later, then it expanded to private and faith-based facilities once accreditation standards were introduced. Then outpatient care was not part of NHIF until much later. I can go on and on and on.
Yeah.
The point I'm making here is, forget what now later happened to NHIF. On paper, the rollout plan made sense, and it was structured. Is it the same with SHA, or are we then looking at the transition from NHIF to now introducing SHA as, for lack of a better word, we have a space, and it's a political space where there was a promise made that we need to do this and we need to do this right now. And so nothing is really properly structured. So everything has been thrown out there for both public, for private, for government civil servants, for anybody who voluntarily wants to get into this, and it's not clear how it works and how it doesn't. Would you agree with me?
I will agree with you. And I would say that if, for example, Social Health Authority was restricted to public, let's say hospital, public health care, then we won't have the problems we're having now. Because you realize that the packages that have been designed, benefit packages that have been put, will make you go to any public facility without being asked to copay or to have additional costs. But because there's also access to the private sector and the private facilities, that's why there's always the copayment, and that's why there's always concerns that are being raised. Ideally, as a union, we even stopped this social authority in court in 2023. We were against a lot of changes that then were being rolled in at different times. I think it was the judgment of last year that gave them the green light to move on. But the one-time rollout of all these social authority was a problem and has been a problem. So what do we do in such a scenario? It is easier to have the social authority with the challenges and get mechanisms to correct them as it provides services than shutting it down.
Sure.
It's
or then reverting to an old
system. Because then that will mean that the funds that you're having are being used for nothing else, for something else. So it's much easier for us all to bring our inputs to get to have real surveillance. Like by 1st of October, it will be a 1 year time since Social Authority was launched. We should give evident problems or challenges that have been experienced over that time and the good things of it for also that period. Because with that aspect, then it's much easier then to see what are the changes we need at benefit package. Because now I've seen a new team in that benefit package. Some very good professors, like Professor Jaoko, people who are very objective what they're doing. We have seen a new change in the CEO of that particular of SHA. We have seen the new PS, Dr. Loga, in the ministry. We have seen the new minister, Duale, who was not there before, which now we are seeing more of a stakeholder engagement in terms of this particular space that was not there before.
Sure.
So I believe that if we get to have an honest conversations of what was the situation in the October 2024, and now the October 2025, what has been the teething problem and how can we solve that? That will give us an honest way to change this and even to get a better way to ensure there's more access. Because I know that the collection from informal sector is still a problem, still a challenge.
Sure.
I know that the burden of SHA is still carried by the salaried workers who form less than 20%. And ideally, for these things to then work as expected, there has to be more money from the budget or from tax to actually cover the Kenyans.
So, Dr. You've mentioned something to deal with stakeholder engagement, because then again, we have hospitals, we have the government that is offering the services, but then again, there is the aspect of sitting down to iron out the problems within SHA. And you say it's about time that this is held, this meeting is held. Is that happening anytime soon? But then again, let's look at 20 million registered SHA members into this kitty, but you look at around 6 million are paying. 6 million are paying, so that means 6 million are carrying the heavy burden. But then again, you look at even policymakers as they go around, and all they keep on telling Kenyans is, you just register. You just register. That is what is important. But we need to have a conversation on how Kenyans are being encouraged to keep on paying so that this pool gets the money that is needed. So brings the next question, which is, stakeholders and government, are they sitting to iron out the problems? And are we as well just speaking to Kenyans to ensure that those who have not paid up, pay up? Because we also know there are those who pay on the day that they are sick for them to get services.
Yeah, I think the model that Social Authority has adopted is quite different from what NHIF had, whereby in NHIF you had to pay and be paying consistently for at least 6 months to access the care. But with Social Authority is that you are sick today, you're asked to pay and you access care tomorrow. So one problem with that is that there's an aspect of bias in that you will pay, get the care, and then forget about paying. And therefore that pulling effect will be lost in the process. I think that's why the handlers of Social Authority ask that if you are paying, you pay for a year. So that when you're going to the hospital seeking care, you're able to support the rest who are not going. But then the reality is there's actual need to empower the public so that they know and question the hospitals so that you know what you're covered and you know what you hope to get in the hospitals. Because sometimes there's also a possibility and with this aspect of co-payment, that the hospitals can always charge you what they want. And this reality, the person who gets distressed is the patient. So by the time you go to Social Authority to complain about this thing and go back to the hospital, you'll already have to pay out of pocket. So that aspect of co-payment, I always believe it can always be misused at the disadvantage of the patient.
So it's clear that the skeleton of this, if you imagine it and you put it down on paper, in terms of the blueprint, it makes sense in terms of how it should work. When you start to then put flesh around it is when you now are dealing with this 20-80% that you speak of. But unfortunately, the majority of the funds or resources that are required for SHA to work in the way in which, assuming that everything is in place, is coming from those funds are not coming in the way in which they should. Like Dennis said, you want to, and I guess that's the behavior, that it is when you have been sick, then now we say, okay, let us pay. And then after having recovered, you also then see the sense in paying in advance, just in case something happens. Now, when we talk about stakeholder engagement, there are very many people in this whole thing. How do we impress upon the minds of people the importance of insurance? Because that is what this is. That you put something today because a problem might come tomorrow. Because that is what this entire system is hedged on. Without that, SHA definitely will not work. And that any money that comes in, because I would imagine that Grace, who is being asked to pay a year in advance, what it comes to about, 3,600, Bob? And she works in the informal sector, that she would expect that she goes to hospital in September and finds the money that the money will be paid for the claims that she has. But you can imagine that when she pays, that money goes immediately to pay for another need that is essentially waiting at the door, isn't it? So how do we get to the place whereby funds paid are not expended immediately and that they can be used for somebody who is coming in the future? How do we impress upon all of us that importance?
You know, if you look at this insurance-based countries like the US, whereby they tend to tie your social services to having paid this particular the Medicare. So that's a mechanism that I think government tried in 2023, whereby they had put it a compulsory before you get your national ID or marriage certificate or any government services, then you are forced to must have been subscribed to the Social Authority. I think we're the first ones to run to court to stop it. But when I look at it on the flip side, there has to be a mechanism. There has to be a way to make people actually have these access, pay these particular premiums and be part of the social service. The other workable aspect that I see now South Africa is adopting, and even adopted in Thailand, is this informal sector. These people that we know that they have not. You cannot count on monthly incomes. What has always been happening is that government always have the two models. You have the model of the salaried paying monthly subscriptions, but then these persons are always covered in the tax-based aspect. So it's part of the tax, like the normal that we pay. Then the government they now kept fix it up and pay on behalf of all these particular persons, that will actually make it easier to have the money that is needed. And I think that's the model. It's the model that we have in social authority. Only that tax part has been put only for primary health care. But if it was a better way, that money should just be provided from the tax.
How do you convince people, though, to put a little bit of something aside in advance? Because that's where it is right now. That we still don't see the importance of it, save for a position of emergency. Now, take the politics aside, because we can't run away from the politics, Daktari, that is clearly evident in this entire authority and the whole system. We know that it exists. But to hazard a guess that if majority of people were putting away something into this pool, that it would make it then easier for us to then look at it and say, actually, you know what, this thing works because all the mechanisms have been put in place, politics aside. Is it possible to impress upon people, or is there such a huge trust deficit that no matter what government comes and says tomorrow, do this so that we can do this for you, people are going to, the first thing they'll say, what do you intend to do with the money?
To be honest, those who have other problems, who have gone to the hospital and the bill comes to maybe 200,000, then you're told to pay your SHA, social authority, 10,000, then it's cleared, tend to say some things very differently when they go to the community and say, okay, actually, this thing helps us.
Yeah.
And even in the former NHIF, there was a big move. You realize that those who are in informal sector used to see the benefit they're getting from it, and they were actually paying for the same. But I really don't want to really look at this insurance problem to be a part of just the government, SHA only. I think private insurance companies are worse in how they're providing care in this country compared even to SHA.
They still renamed them on Monday, quite a number of them actually.
Yeah. Because if you look at even the access to care for most of the public, let's say this public run insurance or SHA, you can't compare it to any of these particular private insurance companies, because these private insurance companies always look for the need not to pay. They need not to cover you. So you will pay the premium, like cases we have, and we have the public sector that are covered. We have, for example, in Kiambu, we have more. Whereby it tells you that if you go for maternity, you pay, and then you claim after. So it builds the basis of actually insurance. We have something like Trident for Vihiga County, I think Bungoma County, where it has been agreed you have the card, you go to the hospital, but you're not covered. And they're telling you the premium was paid 50% by the employer. We have one contract with First Insurance that Moi Teaching and Referral Hospital paid as a contract on the hospitals to cover. Then you go to the hospital, you go to the Eldoret Hospital, you're not covered. So we had to even call a strike for them to actually end up covering. So the issue of the issue of this coverage, yes, we have the public insurance, the SHA, and also we have these many private insurance companies. Their action is even worse. And yesterday we said in our press statement that if you look at the entire package of universal health care, we cannot put that burden on your social authority. We have that burden also with private insurance, because when people say that we have private insurance and we have public insurance, they should all work to ensure there's access.
Yes.
Let's have an honest conversation here, because when it comes to issues of payment, right now in this country, if we were to be very honest with ourselves, I'm just looking at figures. I can't qualify these figures, but practically looking at the low contribution rates across the population, over 23 million Kenyans are registered under SHA, but only 5.6 million are actually contributing.
Employed.
23 million who are registered. All these 23 want to access healthcare, but only 5.6 are actually contributing. Now, that leaves about 17 million registered but non-paying individuals. Obviously, the system will be weakened. Now, the majority of these non-contributors are in the informal sector, which comprises then over 80% of Kenya's workforce. Now, if we are then saying that we need to maybe have a conversation around people getting insurance cover and thinking about putting money into this, a lot of this 80%, it's hand to mouth. They don't even have enough money to save. They don't have even an emergency fund anywhere. You talk you meet 10 people and ask 10 people, how much are you putting on the side for your health insurance cover? How much do you have for emergencies? How much do you have for this and that? The payslip has been slashed so much. You have housing on one side. So by the time you're having a conversation with somebody that you need to consistently pay this because in future you may need this and the other people also need, everybody's on survival mode. Everybody's in survival mode. The moment I get sick is when I will figure out what to do. That's when I will pay for SHA. Is the model not? Is this modeled? And on paper, it's incredible. It should work, but is it modeled around the realities that are in the country? If we are to be honest with ourselves,
that's one of the biggest challenges. I think that's why most hospitals are demanding for their payments, and most of the times. The social authorities say that they'll pay, but they don't pay on time. The reality is health can't be free. And this is one thing that I said and I keep saying. Somebody has to pay. And when we have only 5.5 million paying for the over 20 million or 30 million, then there's a problem. And the way other countries have sorted that particular gap, as I said, I think now South Africa and I think Thailand is doing that, is that informal sector, which we know, I think here we used to call them indigents. The indigents, we have about maybe 1 million or 2 million.
Yes.
The best way is to have government cover that particular difference as part of their social responsibility. It can be in the tax, it can be the allocations. But the moment you only have these particular funds, then it becomes a problem in terms of having access. And one thing I think one of my colleagues say that because of the approach that we have, always because of this particular social aid authority, there's always a continuous increase in the benefit package. But this continuous increase benefit package, like we saw in ICU and we saw in the chronic, and we're now pushing for the cancer, it has to go hand in hand with our contributions. It means that there has to be many more people in the informal sector either contributing or government allocating more funds to that particular SHA. Otherwise, we'll continue making noise and complaining without any tangible outcome. What then that means is that we will be running down saying, this social authority is not working, therefore what can I do as somebody who is employed? I need to get a backup of maybe Jubilee insurance, I need to get a backup of this particular private insurance. Then you realize that these particular insurances will tell you, you must have your SHA working first and claim done on part of SHA before we pay.
But it is not clear that it doesn't work at that instant. By the time, and please, maybe just for some guidance here. By the time you're going to a private insurer to cover, it is already clear that the other one that you have access to, SHA, has not been able to do that for you, isn't it?
No. If you look at the Act, the SHA Act, it says that they say this is what they provide in the packages, and then they say it's free for every Kenyan to get another secondary insurance, something that we were opposed to when it was being done at the Act. But once they provided that, therefore, some employers get for their employees private insurance over and above the SHA.
Yes.
But then the private insurance have put it as a rule that you must exhaust what is provided for you in SHA in terms of the payment that are being done before they pay the extra.
Why? But you've paid your premiums on this private insurance. You can do whatever you want if you've paid, isn't it?
Yeah, that's the reality. But that's what should happen. But this is the reality now. To the point that if, for example, you don't have this SHA, then they will not cover you. We have a case also, again with First Assurance, where a doctor who works in Moitish Referral Hospital takes the wife to the hospital, and because the wife is a foreigner who was not having SHA, but it's part of the First Assurance, it was not covered, so he had to pay out of pocket for this particular bill. That was one of the complaints that we raised, I think 2 or 3 weeks ago. Yeah. So it means that this issue of social aid authority, this issue of private insurances, if you're not checked, then the person who's paying the premiums end up suffering.
Dr. We talk about all these insurances, we talk about stakeholders and everything, but let's look at the goodwill that does exist. And when we talk about goodwill, it's not just about the political class. Let's talk about goodwill of ensuring that healthcare in the country is accessed by all. So we talk in terms of the government in making sure that the bottlenecks policy and the bugs in SHA are fixed. But let's take it further down to Mwananchi making sure that they pay their premium. And let's go to the service providers. So we talk about the hospitals, about the private insurances in making sure that we all come together to ensure that access to healthcare is there. from where you sit, would you say there is an understanding or a common understanding, especially from doctors and hospitals and insurance providers, that there is need to work together to support SHA in ensuring that universal healthcare does exist in the country? Are we speaking the same language?
I think the reality is that we don't speak the same language. We have all been protecting our own personal interests within the field of where we are. Because we see the Social Health Authority looks at how can they minimize expenditure, just like all the other insurance companies see how can we minimize cost or the expenditure, while the private hospitals are looking at how can we maximize profits, while the patient is looking at how can I get quality health care. So a process will go whereby in all these struggles, the person who suffers is the patient. Because the hospitals will look at how do they maximize the profit. It means that they will give you, they'll use the cheapest, the most available products. They'll tell you use generic drugs. They tell you use the most baseline equipment. While the insurance company will be like, this is our cap. Whether it is SHA or any private insurance, this is the cap. You cannot add it anymore. So in all the entirety, the person who's going to get the least, who's going to carry the burden of all this is the patient, because they will not get the care that they need. And that was our complaint yesterday, where some insurance company, and I think even Social Authority, they dictate to the doctors, to the patient, which doctors to see. Because they are doing a paneling. So you find that this doctor A has been empaneled, and that's the only doctor you can see for you to be covered. Or you go to a particular hospital. That if you don't go to Nairobi Hospital, or you don't go to Mata, or you don't go to Aga Khan, you are not covered. And then they dictate to you what tests are being done. You have a doctor who's not getting any benefit from this. He just wants to make you sure that you're getting the right test. But the insurance company says, no, that test we won't cover. And therefore the patient will not have to get that particular test. We have seen this in GA insurance. And doctors complain over these things.
Is it just a random clandestine refusal? Or is it backed with reason?
It's not backed by reason. It's just like, for example, you go to see a doctor and you had maybe a bone problem, or you had an orthopedic refers you to go do a particular X-ray or MRI, but then the insurance says they don't cover that. So it means that is not being done. They will say they cover most basic one of the tests, and in that process, the reality is that the patient is undertreated.
So, Doctor,
and again, to go to a further part is even the drugs. They'll tell you, instead of using, there's some people who have been using these particular brand drugs, mostly those who are in chronic conditions. So the moment you change their chronic drugs into particular generic, you realize that because there are different expressions in these particular drugs, the way that they are, maybe their diabetes or their hypertension was controlled comes to be different. But this insurance company will dictate to them, give this particular generic drugs. So in all these aspects, the insurance companies are for their own interest. They want to ensure that they spend less to maximize the profit. The hospitals are also in their own interest trying to maximize. Now, the person who suffers here is the patient. But if we are all working with one approach, that is the quality, cost-effective healthcare for the patient, then we won't have much of this particular problem.
What will it take for everyone to sit at the table and have this conversation in unison?
We must know that it's not only a responsibility of one person to handle these matters. The doctors need the insurance so that the patient can access the care. And this doesn't matter whether it's a private insurance or the Social Health Authority, and therefore there's no way the social authority can make unilateral decisions on matters of healthcare. They must sit down with the providers and get to have analysis of the costs that are put as packages. And the insurance, the hospitals must also look at the value of giving the patients quality care. So all that we must have the patient's aspect. We must have the healthcare workers. We must have the hospital. We must have the government who now handle this SHA. Because with that common approach, it will be easier to have a better access than if it was only the way it's always happened, where the benefit package of SHA will say, this is what we are covering, nothing else. Because then they say you can charge whatever you charge as long as this is the cap of it. It means that these hospitals will not want to go at a loss. Therefore, they will put extra charges. And that will be borne by the patients who don't have that particular ability. That becomes the problem.
There's a trust deficit. I went for a surgery sometime, I think last year, and I didn't understand it then. Later is when I did, when the insurance cover, they sent the insurance company sent somebody over to my room, and this person was asking, "Oh, so Dennis, so sorry for what you've gone through. Was it successful? Yeah. So what exactly did they do?" So I'm in bed in pain.
Yeah.
And this person is asking me what was the procedure, and ask me a lot of other things. And I'm thinking, why are you asking me this? Then I realize they're actually not coming to check on me. It's a trust issue because they want to verify the claims the hospital is making. Okay, so did you go through this surgery? Really? What did they give you? And I'm like, I can't remember all the medication, but this is what they've been giving me. I've been here for the last 3 days. Da, da, da. And this person is actually noting. Then I figured, how many patients do they do this? How many officers are sent to hospitals to verify that this claim you went through this surgery, this was the procedure done, this is the medication that was used, that indeed that is happened. It's a trust issue. The system is broken.
This is a problem here.
Oh yeah, it is. I think that's also has manifested itself in the Social Health Authority, where they have now brought this aspect of G360, whereby if you are a doctor, you can only see a patient in a particular facility, and that patient can do a claim when you are there. It means that if you are not there, then the claim cannot be done. So,
this is essentially a claim linked to an individual medical practitioner.
Yes.
But there's no space for that in the law. There's no space for that in the authority. There's no space for that with insurance.
Yes, I mean, the Social Authority have a right to do what they're trying to do, though it's against the law. Because they're trying to see that they're trying to see how do they curb these particular frauds that have been occurring. So that's what they think, that if we map every hospital, every doctor to a particular place, they're not going to get this thing to be possible. But the reality is different in terms of, is it possible that this particular doctor will be there at that time to do that particular claim?
Sure.
It will not be possible. And now the person who will suffer in all this particular problem is
the patient.
And therefore there has to be a real conversation on how can this be done to ensure that there is no fraud, at the same time the patient accesses the care.
And that's why we start these conversations. Good for us to put it out there. It's good because we were saying this is how it should work, and we can see the reasons why it's not working. And that it seems collective in nature that everybody's got to put a little bit of a chip onto the block and then see how we can get to it. Dr. Davji Atellah is the Secretary General of the KMPDU, has been here with us this morning talking SHA. Let's see what happens. We'll go through it. Thank you so much, Dr.
Thank you so much, Indu and Double Dennis.
Good morning.
This is the Situation Room, the only way to start your day.